Patients with ALK-rearranged non-small cell phenotypically look very similar to patients with EGFR mutation. By and large, they almost always have adenocarcinoma, a preponderance of never smokers, remote former minimal smokers. Beyond that, however, the oncogenic driver that governs the behavior of the tumor is very different. EGFR mutant tumors are highly sensitive to the EGFR TKIs, such as gefitinib, erlotinib, afatinib. Those drugs do not work in ALK-rearranged tumors. The first agent approved, roughly 5 or 6 years ago, was crizotinib, which actually was developed as a MET inhibitor. It was only incidentally discovered to be an ALK inhibitor. And that agent has stood the test of time, has shown superiority both in terms of response rate and progression-free survival compared to standard second-line chemotherapy, and a little bit more recently in one of the profile trials, single-agent crizotinib was clearly superior to a platinum pemetrexed based regimen in the frontline setting. At least until very recently, it's been the standard of care. More recently, we've seen the emergence of second and third generation ALK TKIs, drugs that are developed specifically against ALK. Ceritinib was one of the first to be looked at in the second and third line setting, and actually salvage patients whose disease had responded and then progressed on crizotinib, with progression-free intervals lasting 6, 7, 8, 9 months. And more recently, it's been compared to chemotherapy in the frontline setting, and has shown clear advantage, median progression-free survival of 16 months or more compared to standard 7 or 8 months. So it too now has a formal approval in the frontline setting.